Assalamu alaikum. I am Bintizia. Today I am with the topic of anaphylactic shock. Anaphylactic shock is a type 1 hypersensitivity reaction. Before proceeding towards the topic, it is important to know about the immune system. Immune system is a protection or immunity from microorganisms agent. It acts as a double-edged sword. From the one side, it's a bless, and from the other side, it's a curse. Allergy word was first introduced by Clemens. It is a combination of two words, alles and argia. Alles means other or different, and argia is energy or action, that is change in the activity or capacity to react. When an antigen enters into the body reacts in the form of hypersensitivity and immunity that results in allergy. There are four types of hypersensitivity reaction. Type 1, that is Ig mediated, take 1 hours, and the example is anaphylaxis. Type 2 is IgG or IgM and cytotoxic mediated. It takes hours to taste, and the example is hemolytic anemia. Type 3 is immune complex mediated. It takes 1 to 3 weeks, and the example are serum sickness and systemic lupus erythematosus. Type 4 is T cell mediated. It takes days to weeks, and the examples are rash and Stevens-Johnson syndrome. Anaphylaxis, first recorded in 2640 before Christ in hieroglyphics as the death of Pharaoh was of bee sting. Richard and Portrier in 1902 coined the terms anaphylaxis during their experiment of dog immunization. They give actinia extracts to the dog, and when they repeat the dose, the dog died within 25 minutes, and they were given Nobel Prize. Anaphylaxis is a combination of two words, ana and phylaxis, that is contrary to protection. Anaphylaxis is a generalized immunological condition of sudden onset which develops after exposure to a foreign substance. Anaphylactic shock is a systemic type 1 hypersensitivity reaction that often has a fatal consequences. Pathophysiology: when allergen enter into the body, antigen presenting cells engulf them and digest it and present its particles on its surface. T helper cells that found in the body detect that particles in the form of signals and attach to it and activate the beta cells through the interleukins. Beta cell activation results in Ig production. The IgE then bind to the mast cells through the Ig receptors. When allergen again enter into the body, they bind to the IgE that results in degranulation of mast cells, and which cause release of the histamines, leukotrienes, prostaglandins, and platelet activating factors, which in turn cause anaphylaxis. Statistics and incidences. Worldwide, anaphylaxis affect 0.05 to 2% of the population. It occurs in young people and in female. In United States, about 0.3% people die with anaphylaxis. In Pakistan, reported incidence ranging from 10.5 to 21 cases per 1 lakh person years, and risk of death is 1%. According to researchers, cases of anaphylaxis occur 13% at hospitals or clinics, 6.4% at relatives or a friend's home, 6.1% in workplace, 6.1% in restaurants, and 2.6% at school. Triggers include foods, drugs, and hymen opera venum. Foods account for 33%, that is peanuts, fish, eggs, pulses, and shellfish. Drugs account for 26%, that include antibiotics, especially penicillin, aspirin, NSAIDs, and anesthetics agent. Hymenoptera account for 28%. Clinical presentation include in skin, itching, erythema, urticarial, angioedema. Respiratory includes sneezing, runny nose, claws, coughing, wheezing, shortness of breath. Central nervous system include anxiety, dizziness, slurred speech. Cardiovascular system include hypertension, tachycardia, rapid pulse, coronary artery swell. And GIT include abdominal pain, vomiting, diarrhea, urine incontinence. Anaphylaxis is a clinical diagnosis, so there are no specific investigations. Sensitivity tests include patch test, elimination test, challenge test. Other include plasma histamine levels and serum total tryptase level. Prevention include avoid exposure to allergens, desensitization, and monitoring. Complications include respiratory obstruction, systemic vascular collapse. Management: anaphylactic shock is a life-threatening condition, so assess for airway, swelling, hoarseness, stridor, breathing For breathing, rapid breathing, wheeze, fatigue, sinuses, saturation will be less than 92% and confusion. For circulation, pale and clammy skin, low blood pressure, faintness, drowsy and coma, weak or absent central pulse. Treatment include remove trigger, whatever causing the anaphylactic reaction, maintain airway, give oxygen. First line treatment include epinephrine plus fluid resuscitation plus nebulization. Second line treatment include histamine antagonists and corticosteroids. If cardiac arrest, go for CPR, admit or observe for initial treatment. First line treatment include epinephrine and the route of administration is intramuscular, that is a lateral aspect of thigh. Repeat every 5 to 10 minutes if necessary. Dose is 1 to 1000 ratio dilution. Injection, that is 0.2 to 0.5 ml. For children, the dose is 0.01 mg per kg and the maximum dose that can be given is 0.3 mg. In adults treated with adrenaline auto-injector, that is EpiPen, the dose is 300 mics. Action of epinephrine. Epinephrine act on alpha-1 adrenergic receptors, and by acting on this receptor, it increases the vasoconstriction, increase peripheral vascular resistance, increase heart rate, decrease mucosal edema. By acting on alpha-2 adrenergic receptor, it decreases insulin release. By acting on beta-1 adrenergic receptors, it increases inotropy, increase chronotropy. And by acting on beta-2 adrenergic receptors, it increases bronchodilation, increase vasodilation, increase glycogenolysis, and decrease mediator release. IV epinephrine. IV route is not recommended, but if repeated IM doses are needed, patient may benefit from IV dosing. The dose is titrate IV adrenaline using 50 mics boluses according to response. The pre-filled 10 ml syringe of 1 into 10,000 adrenaline contains 100 mics per ml. Fluid therapy include crystalloids and colloids. The most important is not the composition but rather than the rate of administration. For adults, 500 to 1000 ml. For children, crystalloids 20 ml per kg. Stop IV colloid if it might be the cause of anaphylaxis. Second line treatment, that is histamine antagonist, H1 blockers, chlorpheniramine against itching, dose 10 to 20 mg slow IV. H2 blockers include ranitidine, dose 50 mg IV. Corticosteroids include hydrocortisone, methylprednisolone that prevent recurrent anaphylaxis. Dose is 100 to 200 mg slow IV. For refractory hypertension, give dopamine at the dose of 400 mg in 500 ml normal saline, and for infusion, give 2 to 20 microgram per kg per minute. Glucagon, dose is 1 to 5 mg, that is 20 to 30 microgram per kg, maximum 1 mg in children. IV over 5 minutes followed with continuous IV infusion 5 to 15 microgram per minute. Nursing management include nursing assessment, that is communication is an essential part of assessment. Assess any kind of allergy, assess patient's knowledge for previous reaction. New allergy, advise the patient to wear or carry identification of allergen. Nursing diagnosis based on assessment data are impaired gas exchange, altered tissue perfusion, ineffective breathing pattern, acute pain, and impaired skin integrity. Nursing goals are maintenance of effective breathing, demonstration of improved ventilation, display of hemodynamic stability, verbalization about understanding of allergic reaction, its prevention and management, verbalization about understanding of need to carry emergency components for intervention. Nursing interventions include monitor client's airway, monitor the oxygenation status, focus breathing, positioning, limit activity, monitor hemodynamic parameters, and monitor urine output. Evaluation include expected patient outcomes, that is maintain effective breathing pattern, improve ventilation, hemodynamic stability, understanding of allergic reaction, its prevention and management, understanding of need, carry emergency component for intervention, and the importance of seeking medical care. Patients who are at risk for anaphylaxis, the universal recommendations are across available guidelines, epinephrine auto-injector 2 doses, auto-injector training, education on avoidance of allergen, follow-up with primary care physician, referral to allergist if first presentation or cause is unknown, monitor auto-injector expiration dates, and block auto-injector substitution at pharmacy. If you like the video, kindly subscribe my channel. Thank you.